We're at the 2018 CROI. We're here with Gustavo Velasquez from the Brigham and Women's Hospital here in Boston. And so you're local, so you're here on and off. And but we grabbed a hold of you quickly because you have high-dose rifampin for TB. And I think well, let's let you set it up, because I think it'd be better if you explain how this research went.
Yeah, thank you. So the background for the study is that rifampin is an old drug. It's been around since the middle of last century, and rifampin is part of it's the most potent sterilizing drug for tuberculosis that we have. The dose that we use for rifampin, however, the current dose is 10 milligrams per kilogram, or in most people that's 600 milligrams. That dose was chosen back in the 60s and 70s for many reasons, but one of them was actually cost. It was a very expensive medication when it first came out.
So they went with as much as what they had to have to make it maybe work.
Right, exactly. And I think that there was a concern that higher doses would be more expensive regimens. There were some studies in the 70s that looked at increasing the dose of rifampin further to try to shorten treatment even more. But since, again, they were concerned about cost, they increased the dose, but they gave intermittent dosing, so not to have to use as much. Those trials showed that unfortunately there was more toxicity with the higher intermittent doses. Okay, so there was there were several decades where there was no kind of further investigation of this question about using higher rifampin doses until more recently. Now there's been several trials that have published on the safety and sometimes the pharmacokinetics of higher doses of daily rifampin. And so what we did in our trial, the high-RIF trial, was we did a phase 2 randomized controlled blinded study to look at the pharmacokinetics, efficacy, and safety of 3 different doses of rifampin. The standard dose, which is 10 mg per kg, compared to 15 and 20, so up to double the dose. The pharmacokinetics results have been published before, and I will just say very briefly 2 big takeaways from that part of the study were that first, we found, as others have found, that with higher rifampin doses, the concentration in the blood goes up at least proportionally, and some studies have shown more than dose proportionally. The second thing that we showed is that in the patients who received the control arm, we found an unexpected result. About two-thirds of them actually had low concentrations of rifampin, what we would call low. Specifically, the peak level of rifampin in the blood was under the target of 8, the number 8.
Right.
And so I think there's at least in our study, there were certainly some patients that you could say were being underdosed, even at standard dose.
Right.
So
and that was based upon weight, the weight of the patient.
So it was based on their peak rifampin dose, based on what arm they were in. So standard dosing or 15 or 20.
Right.
So what we did and what I presented today was the efficacy and safety findings. So the efficacy outcome that we were interested in, the primary one, was do higher doses of rifampin sterilize the sputum faster? So we looked at the decline of living TB bacteria in people's sputum, which was measured 9 times during the first 2 months. And we looked to see that rate of decline if it was different based on the dose that you received. The finding was that in what we call the quote-unquote modified intention to treat population, which were the patients who had enough and sufficient data of these counts in their sputum to analyze, we found that higher doses of rifampin were associated with the trend towards a faster decline, but that itself was not significant. We had a secondary analysis of the per protocol population, which was patients that received the rifampin dose they were assigned, and in that we did find a significant difference. So there was a significantly faster decline in counts of TB and sputum. Also, we found that in patients who had higher concentrations of rifampin in the blood, so now looking at it by concentration, not by dose, there was also a faster decline in sputum. Safety was another big thing that we looked at in the study, and so we looked at the number of patients who had one or more grade 2 adverse events during the study, and those were actually similar across the 3 doses. So I think this study adds to these other controlled studies that have shown that higher doses of rifampin seem to be safe.
And was there any ability to see that you could shorten the course of treatment?
Right. So, so we did have some secondary efficacy outcomes of 8-week culture conversion. That we found actually was similar across the 3 arms. And we also had the kind of the ultimate outcome of 12-month outcome. So the treatment is only 6 months, but we looked at patients for 12 months to see if they would recur during 6 months of follow-up at the end. And that also, so the proportion of recurrence-free cure was similar. The proportion of treatment failures and recurrences were similar across the arms. There were 11 of those patients that had recurrence or failure. There were no deaths. And so of the 11 that had recurrence or failure, 6 actually were in the control arm. So although the number was slightly higher in that control arm, there was no statistically different difference there. And so, I can tell you that in the control arm there were 3 treatment failures and 3 recurrences, and using genotyping we were able to confirm that 2 of the recurrences were relapsed disease in the control arm. So there was a trend towards a slightly better outcome, but we can't really say that because it was not significant. So I think that at least at the doses that we looked at, the 20 mg per kg, 20 doesn't seem to be enough. 20 does seem to be safe, but it doesn't seem to be enough to shorten therapy. And there is at least one clinical trial being done by the Panacea Consortium in Africa that's looking at even higher doses of rifampin to potentially get the course of therapy down.
So when you say that's ongoing in Africa,
Yeah, it is ongoing.
So what is your next steps?
So it's a great question. I think one of the things that I brought up in the session was that, first of all, we had this finding that some of the patients in the control arm were being underdosed. We have some blood samples collected in the patients from this trial, and so one study that we're planning on doing is looking at the pharmacogenetics, so seeing if there are genetic differences in the patients that achieve lower doses, because that could potentially be something that you could test up front and then know that your patients could be underdosed at standard dose and therefore they need more. The other thing is just overall, there's now increasing data that shows that the rifampin at higher doses is safe, and at least in looking at the sputum, that microbiologic outcome there seems to be some benefit there, although the final outcomes are very blunt instruments and it's difficult to tell the difference. So another question that I think this trial brings up is, should we consider using higher doses than we do right now until we find that ultimate best higher dose beyond what we studied today.
Relative to the cost concerns of the early days, was it because the drug was new and it was not, and so now it's much less expensive?
Yeah, so I'm less familiar about what the cost was back then, but I know that it was only a decade or two out, it had just been released. Nowadays, rifampin's available throughout the world, for tuberculosis. It's pennies a tablet.
Wow.
So I think that it's not, I don't think that itself is much of a concern anymore.
Great. Well, I'm glad that we're re-looking at things. Sometimes that was then and this is now.
Correct.
We got to rethink everything
Yes.
based upon changes here, incremental changes over the years. But we always want the drug prices to be lower, don't we?
Right, correct.
So we always work towards that. Well, I thank you very much for giving this insight into the higher dose of rifampin, and hopefully we'll come out to the real number that we need to know.
Yes, thank you very much.
Thank you.
I appreciate it.
Yep.
Thanks.